Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Unit 7, Psychotherapeutic Drugs. We'll specifically talk about Chapter 28, the Management of Anxiety Disorders. So we'll jump right in. Anxiety is an uncomfortable state that has both psychological and physical components. The psychological components can be characterized with terms such as fear, apprehension, dread, and uneasiness. The physical component manifests as tachycardia, palpitations, trembling, dry mouth, sweating, weakness, fatigue, as well as shortness of breath. Anxiety is a nearly universal experience that often serves as an adaptive function. When anxiety is moderate and situationally appropriate, therapy may not be needed or even desirable. In contrast, when anxiety is persistent and disabling, intervention is clearly indicated. Anxiety disorders are among the most common psychiatric illnesses. In the United States, about 25% of people develop pathologic anxiety at some time in their lives. As a rule, the incidence is higher in women than in men. In this chapter, we focus on five of the more common anxiety disorders: generalized anxiety disorder, panic disorder, obsessive compulsive disorder or OCD, social anxiety disorder, and post-traumatic stress disorder or PTSD. Although each type is distinct, they all have one element in common: an unhealthy level of anxiety. In addition, with all anxiety disorders, depression is frequently comorbid. Fortunately, anxiety disorders often respond well to treatment, either psychotherapy, drug therapy, or a combination of both. For most patients, a combination of psychotherapy and drug therapy is more effective than either modality alone. As indicated in the following table, two classes of drugs are used most: benzodiazepines and selective serotonin reuptake inhibitors, or SSRIs. Benzodiazepines are used primarily for one condition: the generalized anxiety disorder. In contrast, SSRIs are now used for all anxiety disorders. It should be noted that although SSRIs were developed as an antidepressant, they can be very effective against anxiety, whether or not depression is or is not present. So, the following table here shows the first line drugs for anxiety disorders. If you're unfamiliar, hit that pause button. Otherwise, we'll jump right on and we'll see how we would treat each of the following. So, generalized anxiety disorder. The characteristics. Generalized anxiety disorder, or GAD, is a chronic condition characterized by uncontrollable worrying. Of all anxiety disorders, GAD is least likely to remit. Most patients with GAD also have another psychiatric disorder, usually depression. GAD should not be confused with situational anxiety, which is a normal response to a stressful situation. Symptoms may be intense, but they are temporary. The hallmark of GAD is unrealistic or excessive anxiety about several events or activities that last 6 or more months or even potentially longer. Other psychological manifestations include vigilance, tension, apprehension, poor concentration, and difficulty falling or staying asleep. Somatic manifestations include trembling, muscle tension, restlessness, and signs of autonomic hyperactivity, such as your palpitations, tachycardia, sweating, and cold, clammy hands. So, the prototype drugs. Drugs for anxiety disorders again are our benzodiazepines, for which we'd be talking about diazepam, and our non-benzodiazepines, or non-barbiturates, which would be our buspirone. So, for treatment, GAD can be managed with non-drug therapy and with drugs. Non-drug approaches include supportive therapy, cognitive behavioral therapy, or CBT, biofeedback, and relaxation training. These can help relieve symptoms and improve coping skills in anxiety-provoking situations. When symptoms are mild, non-drug therapy may be all that is needed. However, If symptoms are intensely uncomfortable or disabling, drugs are indicated. In 2015, guidelines for treatment of GAD were published in the American Family Physician. Current U.S. Food and Drug Administration or FDA approved first-line choices for treatment of GAD include benzodiazepines, buspirone, and 4 antidepressants, venlafaxine, paroxetine, escitalopram, and duloxetine. Although other drugs are recommended for the treatment of GAD, they are currently used off-label. With the benzodiazepines, onset of relief is considered rapid. In contrast with buspirone and the antidepressants, the onset is delayed. Accordingly, benzodiazepines are preferred drugs for immediate stabilization, especially when anxiety is severe. However, for long-term management, buspirone and the antidepressants are preferred. Because GAD is a chronic disorder, initial drug therapy should be prolonged, lasting at least 12 months and possibly longer. Unfortunately, even after an extended treatment, drug withdrawal frequently results in a relapse. Therefore, for many patients, drug therapy must continue indefinitely. So, speaking on benzodiazepines. Again, benzodiazepines are the first choice drugs for anxiety. Benefits derive from the enhancing responses to gamma aminobutyric acid, or GABA, an inhibitory neurotransmitter. Onset of benefits is immediate, and the margin of safety is high. Principal side effects are sedation and psychomotor slowing. Patients should be warned about these effects and informed that they will subside in 7 to 10 days. Because of their abuse potential, benzodiazepines should be used with caution in patients known to abuse alcohol or any other type of psychoactive substance. Long-term use of benzodiazepines also carries a risk for physical dependence. Withdrawal symptoms include panic, paranoia, and delirium. These can be especially troubling for patients with GAD. Furthermore, they can be confused with a return of pre-treatment symptoms. Accordingly, clinicians must differentiate between a withdrawal reaction and a relapse. To minimize withdrawal symptoms, benzodiazepines should be tapered gradually over a period of several months. If relapse occurs, treatment should resume. Of the 12 benzodiazepines available, 6 are approved for anxiety. The agents prescribed most often are Xanax and Ativan. However, there is no proof that any one benzodiazepine is clearly superior to the others. Therefore, selection among them is largely a matter of the prescriber's preference. Dosage for anxiety are shown in the following table. So here's an excellent spot to hit pause so you can see all the different kinds of benzodiazepines or medications approved for anxiety disorders, their initial dosages as well as the usual range. So we will start talking about buspirone next. Its actions and therapeutic use. Buspirone is an anxiolytic drug that differs significantly from the benzodiazepines. Most notably, buspirone is not a central nervous system depressant or CNS depressant. For treatment of anxiety, buspirone is as effective as the benzodiazepines and has two distinct advantages. It has no abuse potential, and it does not intensify the effects of CNS depressants, benzodiazepines, alcohol, and barbiturates. Its major disadvantage, however, is that anxiolytic effects develop very slowly. Initial responses take a week to appear, and several more weeks must pass before responses start to peak. Because the therapeutic effects are delayed, buspirone is not suitable for as-needed use or for a patient who needs immediate relief. Buspirone has no abuse potential and thus may be especially appropriate for patients known to abuse alcohol and other drugs. Because it lacks depressant properties, buspirone is an attractive alternative to benzodiazepines in patients who require long-term therapy but cannot tolerate benzodiazepine-induced sedation and psychomotor slowing. Buspirone is labeled only for short-term treatment of anxiety. However, the drug has been taken for as long as a year with no reduction in benefit. Buspirone does not display any kind of cross-dependence with benzodiazepines. Hence, when patients are switched from benzodiazepine to buspirone, the benzodiazepine must be tapered slowly. Furthermore, because the effects of buspirone are delayed, buspirone should be initiated 2 to 4 weeks before beginning benzodiazepine withdrawal. The mechanism by which buspirone relieves anxiety has not been established. The drug binds with high affinity to receptors for serotonin and with lower affinity to receptors for dopamine. Buspirone does not bind to receptors for GABA or benzodiazepines. The pharmacokinetics. Buspirone is well absorbed after oral administration but undergoes extensive metabolism on its first pass through the liver. Administration with food delays absorption but enhances bioavailability. The drug is excreted in part by the kidneys, primarily as its metabolites. Adverse effects. Buspirone is generally well tolerated. However, the most common reactions do include dizziness, nausea, headache, nervousness, sedation, lightheadedness, and excitement. Furthermore, it poses little or no risk for suicide. Huge doses have been given to healthy volunteers with only a moderate adverse effect. Again, nausea, vomiting, dizziness, drowsiness, and meiosis. Drug and food interactions. Levels of buspirone can be greatly increased, 5 to 13-fold, by erythromycin and ketoconazole. Levels can also be increased by grapefruit juice. Elevated levels may cause drowsiness and subjective effects, dysphoria, feeling spacey. Buspirone does not enhance the depressant effects of alcohol, barbiturates, and other CNS depressants. Bringing us to tolerance, dependence, and abuse. Buspirone has been used for up to a year without any evidence of tolerance, physical dependence, or a psychological dependence. No withdrawal symptoms have been observed upon termination. There is no cross-tolerance or cross-dependence between buspirone and the sedative hypnotics. Buspirone appears to have no potential for abuse and therefore is not regulated under the Controlled Substance Act. Which brings us to antidepressants: venlafaxine, paroxetine, escitalopram, and duloxetine. At this time, only 4 antidepressants, as mentioned above, are approved for GAD. Venlafaxine and duloxetine are serotonin norepinephrine reuptake inhibitors, so SNRIs. Paroxetine and escitalopram are SSRIs. All 4 drugs are especially well suited for patients who have depression in addition to GAD. However, they are also effective even when depression is absent. As with buspirone, anxiolytic effects develop slowly. Initial responses can be seen in a week, but optimal responses require several more weeks to develop. Because relief is delayed, the antidepressant cannot be used as needed. Compared with benzodiazepines, the antidepressants do a better job of decreasing cognitive and psychic symptoms of anxiety, but are not as good at decreasing somatic symptoms. In contrast to benzodiazepines, antidepressants have no potential for abuse. However, abrupt discontinuation can produce withdrawal symptoms. Venlafaxine, an SNRI, was the first antidepressant approved for GAD. The drug has been proved effective for both short-term and long-term use. The most common side effect is nausea, which develops in 37% of patients. Fortunately, nausea subsides despite continued treatment. Other common reactions include headache, anorexia, nervousness, sweating, daytime somnolence, and insomnia. In addition, venlafaxine can cause hypertension, although this is unlikely at the dose used for GAD. Combining venlafaxine with a monoamine oxidase inhibitor, or MAOI, can result in serious toxicity, and therefore must be avoided. Paroxetine and escitalopram are the only SSRIs approved for GAD. These drugs are as effective as the benzodiazepines, but less well tolerated. The basic pharmacology of venlafaxine, paroxetine, escitalopram, and duloxetine were discussed in Chapter 25. Which brings us to panic disorders. Its characteristics. Panic disorders are characterized by recurrent, intensely uncomfortable episodes known as a panic attack. A panic, a panic attack is an abrupt surge of intense fear or intense discomfort during which four or more of the following are present: palpitations, pounding heart, racing heartbeat, sweating, trembling or shaking, sensation of shortness of breath or smothering, feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheadedness or faint, chills or heat sensation, paresthesias, derealization or depersonalization, fear of losing control or going crazy, or fear of dying. Panic symptoms reach a peak in a few minutes and then dissipate within 30 minutes. Many patients go to the emergency department because they think they are having a heart attack. Some patients experience panic attacks daily, others only have one or two a month. Panic disorders is a common condition that affects 1.6% of Americans at some time in their lives. The incidence in women is 2 to 3 times the incidence in men. Onset of panic disorder usually occurs in the late teens to early 20s. The underlying cause of a panic disorder is unknown. However, malfunction of the brain's alarm system is suspected. This malfunction may result from abnormalities in noradrenergic systems, serotonergic systems, or benzodiazepine receptors. Genetic vulnerability also may play a role. So, its treatment. Between 70 and 90% of patients with a panic disorder respond well to treatment. Two modalities have been employed: drug therapy and CBT. Combining drug therapy with CBT is more effective than either modality alone. So, as a rule, patients experience rapid and significant improvement. Drug therapy helps suppress panic attacks, whereas CBT helps patients become more comfortable with situations and places they've been avoiding. Additional benefits can be derived from avoiding caffeine and sympathomimetics, avoiding sleep deprivation, and doing regular aerobic exercise. Drug therapy should continue at least 6 to 9 months. Stopping sooner is associated with a high rate of relapse. Which leads us to our antidepressants. Panic disorder responsible to all four classes of antidepressants: SSRIs, SNRIs, tricyclic antidepressants, and MAUIs. With all four, full benefits take between 6 to 12 weeks to develop. Owing to better tolerability, SSRIs are generally preferred. The basic pharmacology of the antidepressant is discussed in Chapter 25. So, speaking on SSRIs, again, they are the first line drug for panic disorder. At this time, there are three SSRIs: Prozac, Paxil, and Zoloft, which are approved for this condition. However, other SSRIs appear just as effective. The SSRIs decrease anticipatory anxiety, avoidance behavior, and the frequency and intensity of attacks. Furthermore, SSRIs decrease panic attacks regardless of whether the patient is actually depressed. However, if the patient does have coexisting depression, antidepressants will benefit the depression as well as the panic disorder simultaneously. Common side effects again include nausea, headaches, insomnia, weight gain, and sexual dysfunction. In addition, SSRIs can increase anxiety early in treatment. Which brings us to venlafaxine. In patients with panic disorder, extended release venlafaxine or Effexor XR, an SNRI, can induce remission, prevent relapses, and improve quality of life. In clinical trials, efficacy was equal to that of paroxetine, an SSRI. The initial dosage is 37.5 milligrams per day for 7 days. Daily maintenance doses range between 75 milligrams and 225 milligrams. But again, The pharmacology of venlafaxine was discussed in Chapter 25. Which brings us to the tricyclic antidepressants. The TCAs, tofranil, anafranil, are second-line drugs for panic disorder. They should be used only after a trial with at least one SSRI has failed prior. Although TCAs are as effective as SSRIs, they are less well tolerated, and the most common side effects include sedation, orthostatic hypotension, and anticholinergic effects, so dry mouth, blurred vision, urinary retention, constipation, and tachycardia. Of greater concern, TCAs can cause fatal dysrhythmias if taken in overdose. As with the SSRI, dosage should be low initially and then gradually be increased. For clomipramine, the initial dosage is 25 milligrams per day, and the target range is 50 to 200 milligrams per day. For imipramine, the initial dosage is 10 milligrams per day, and the target range is between 100 and 300 milligrams per day. Which takes us to the MAOIs. Although MAOIs, such as phenylacine, are very effective in panic disorder, they are difficult to use. MAOIs can cause significant side effects, which again include orthostatic hypotension, weight gain, and sexual dysfunction. In addition, they can cause hypertensive crisis if the patient takes certain drugs or consumes foods that are rich in tyramine. Because of these drawbacks, MAOIs are considered the last-line drugs for panic disorder. Which brings us to benzodiazepines. Although benzodiazepines are effective in panic disorder, they are now considered second-line drugs because, again, unlike the SSRIs, benzodiazepines pose a risk for abuse, dependence, and the rapid re-emergence of symptoms after discontinuation. Of the available benzodiazepines, the agents used most often are Xanax and Klonopin, as well as Ativan. All three provide a rapid and effective protection against panic attacks. These drugs also reduce anticipatory anxiety and phobic avoidance. Which brings us to OCD, also known as obsessive compulsive disorder. OCD is a potentially disabling condition characterized by persistent obsessions and compulsions that cause marked distress, which consume at least 1 hour a day and significantly interfere with daily living. An obsession is defined as a recurrent, persistent thought, impulse, or mental image that is unwanted and distressing and comes involuntary to mind despite attempts to ignore or suppress it. Common obsessions include the fear of contamination, aggressive impulses, a need for orderliness or symmetry, and repeated doubts. A compulsion is a ritualized behavior or mental act that the patient is driven to perform in response to his or her obsessions. In the patient's mind, carrying out the compulsion is essential to prevent some horrible event from occurring. If performing the compulsion is suppressed or postponed, the patient experiences increased anxiety. Common compulsions include hand washing, mental counting, arranging objects symmetrically, and hoarding. Patients usually understand that their compulsive behavior is excessive and senseless, but nonetheless are unable to stop. So, it's treatment. The 2013 Practice Guide for the Treatment of Patients with OCD, published by the American Psychiatric Association, indicated that patients with OCD respond to drugs and to behavioral therapy. Again, optimal treatment consists of a combination of both. As a last resort, patients with severe resistant OCD can be treated with deep brain stimulation. Behavioral therapy is probably more important in OCD than in any other psychiatric disorder. In the technique employed, patients are exposed to sources of their fears, while being encouraged to refrain from acting out their compulsive rituals. When no dire consequences come to pass, despite their absence of protective rituals, patients are able to gradually give up their compulsive behavior. Although this form of therapy causes great anxiety, the success rate is high. So there are 5 drugs that are approved for OCD, 4 of which are SSRIs and 1 TCA. All 5 enhance serotonergic transmission. The SSRI are better tolerated than clomipramine and are therefore the preferred medications. So the 4 SSRIs that we're talking about, which are again the first line drugs for OCD: Prozac, Luvox, Zoloft, and Paxil. However, the remaining 2, Celexa and Lexapro, can also be effective. So, technically, all 6 reduce symptoms by enhancing serotonergic transmission. They are all equally effective, although individual patients may respond better to one than another. With all 6 beneficial effects being developed slowly, taking several months to become maximal, common side effects include nausea, headache, insomnia, and sexual dysfunction. Weight gain may also occur. Despite this array of side effects, SSRIs are safer than clomipramine and are better tolerated. Therapy of an initial episode should continue for at least 1 year, after which discontinuation may be trialed. Withdrawal should be done slowly, reducing the dosage by 25% every 1 to 2 months. Unfortunately, relapses are common, and it is estimated that they range from 23 to as high as 90%. If a relapse continues to occur after 3 or 4 attempts at withdrawal, lifelong treatment might be indicated. Which brings us to the social anxiety disorder. Its characteristics of social anxiety disorder are characterized by an intense, irrational fear of situations in which one might be scrutinized by others, or might do something that is embarrassing or humiliating. Exposure to the feared situation almost always elicits anxiety, so as a result, the person avoids the situation, or, if it can't be avoided, endures it with intense anxiety. Social anxiety disorders have 2 principal forms: generalized and performance only. In the generalized form, the person fears nearly all social and performance situations, while in performance only form, fear is limited to speaking or performing in public. Social anxiety disorder can be very debilitating. In younger people, it can delay social development, inhibit participation in social activities, impair acquisition of friends, and make dating difficult or even impossible. It can also preclude pursuit of higher education. In the older adult, it can severely limit social and occupational options. Social anxiety disorders are one of the most common psychiatric disorders and the most common anxiety disorder. In the US, 13 to 40% of the population is affected at some time in their lives. The disorder typically begins in the teenage years and, if left untreated, is likely to continue lifelong. So, its treatment. Social anxiety disorder can be treated with psychotherapy, drug therapy, or both. Again, studies indicate that psychotherapy, both cognitive and behavioral, can be as effective as drugs. However, the combination of psychotherapy plus medication is likely to be more effective than either modality alone. The SSRIs are considered first-line drugs for most patients. These drugs are especially well suited for patients who fear multiple situations and are obliged to face those situations on a regular basis. Only 2 SSRIs, Paxil and Zoloft, are approved for social anxiety disorder, but our available data indicates that the other SSRIs are just as effective. Initial effects can take 4 weeks to develop, and again, optimal effects are seen in 8 to 12 weeks. Patients should be informed that benefits will be delayed. Benzodiazepines, such as Klonopin, Xanax, are an option for some patients. These drugs are well tolerated and their benefits are immediate, unlike those of SSRIs. As a result, benzodiazepines can provide rapid relief and can be used as needed. Accordingly, these drugs are well suited for people whose fear is limited to performance situations and who must face those situations only occasionally. The usual dosage is 1 to 3 milligrams per day for clonazepam and 1 to 6 milligrams for alprazolam. Propranolol or Inderal and other beta blockers can benefit patients with performance anxiety. When taken 1 to 2 hours before a scheduled performance, a beta blocker can reduce symptoms caused by the autonomic hyperactivity. Doses are relatively small, only 10 to 80 milligrams for propranolol. Which brings us to post-traumatic stress disorder. PTSD develops after a traumatic event that elicited an immediate reaction of fear, helplessness, or horror. PTSD has 3 core symptoms: re-experiencing the event, avoiding reminders of the event, and a persistent state of hyperarousal. A traumatic event is one that involves a threat of injury or death, or a threat to one's physical integrity. Many events may meet this criteria. Among these are physical and sexual assault, rape, torture, combat, industrial explosions, serious accidents, natural disasters, being taken hostage, displacement as a refugee, and terrorist attacks, such as the one that took place during 9/11. It should be noted that PTSD can affect persons who only witnesses to a traumatic event, not just those who were directly involved. The epidemiology of PTSD is revealing. In the US, more than 5 million Americans have PTSD in any given year, making PTSD the 4th most common psychiatric disorder. PTSD develops in 5 to 6% of men at some time in their lives, and 10 to 14% of women. Traumatic events that involve interpersonal violence are more likely to cause PTSD than are traumatic events that do not. For example, among rape victims, the incidence of PTSD is 45.9% for women and 65% for men. In contrast, among a natural disaster survivor, the incidence is 5.4% for women and 3.7% for men. Combat carries a high risk for PTSD. The disorder develops in up to 40% of soldiers who end up going to war. So, how do we treat it? PTSD can be treated with a psychotherapy and with drugs, as described in the recent evidence-based guideline by the Practice Guideline for Management of PTSD, released by the Department of Veterans Affairs and the Department of Defense in 2010. 2 basic types of psychotherapy are recommended: trauma-focused therapy and stress inoculation training. Trauma-focused therapy uses a variety of cognitive behavioral techniques, including a very effective one known as exposure therapy, in which patients repeatedly reimagine traumatic events as a way to make those events lose their power. Stress inoculation training helps patients identify cues that may trigger fear and anxiety, and then teaches them techniques to cope with those disturbing reactions. Regarding drugs, evidence of efficacy is strongest in the 3 SSRIs: fluoxetine, paroxetine, and sertraline, and 1 SNRI, venlafaxine. Of these 4 drugs, only 2, paroxetine and sertraline, are approved by the FDA for PTSD. If none of the first-line drugs are effective, the guidelines suggest several alternatives: mirtazapine, a TCA, amitriptyline or imipramine, or Maui, phenelzine. Current evidence does not support the use of monotherapy with bupropion, buspirone, trazodone, or a benzodiazepine. And that concludes our chapter here for today. I thank you as always for listening, and I'll see you at the next one. Thank you, and have a good day.